The hit show on HBO, The Pitt, has been blowing up. People have said it's the most realistic medical drama of all time. As a board-certified internal medicine doctor and a hospitalist for over 10 years, I'm gonna break it down clip by clip and see if they're right.
Last name?
It's J.A. Jackson.
Okay, doctors don't always wear white coats to work. I just feel like I should bring that up right now because he's wearing a hoodie, a zip-up hoodie. He looks pretty casual, but he's obviously a doctor because you want to have casual, comfortable clothes that you can be flexible and agile in case of emergencies. You need to do chest compressions. It's actually very physically intensive.
Time for my weekly spanking.
Be nice for all our sakes. You sure you're cool being here today?
Yeah? Where wouldn't I be?
Well, if you need to talk.
Yeah, I won't, but thanks. Where's Abbott?
Getting some air. Today's the day Doc Adamson died. He hasn't worked it in 4 years.
Okay, so that's what it is. So obviously there's some tension at the beginning of this show where someone in charge is asking this doctor if he's okay. And then he's asking where his colleague is, and he's like, he's getting some fresh air. So now she told us that someone died 4 years ago.
So why is he here?
All I know is he still blames himself for Adamson's death. So if he's a little prickly today, give him a pass, okay?
Great.
Thank you. Hang in there, kid.
That woman looks like she's in charge, first of all. The way she gave her those eyebrows, which was like, do the right thing, and I'm doing this to help all of you guys. I'm pretty sure she's a nurse. And the way she's dressed is kind of like a charge nurse. And yeah.
Morning, Jack.
That's a great shot for the movies, but it's a little daunting because it's the roof of a hospital, and the way he's standing outside the edge of the railing is really concerning. I mean, I would have loved to end all of my night shifts watching the sunrise, but more likely than not, he's probably having some pretty negative thoughts up there.
What are you doing here?
I'm working. And you?
Well, I don't know. Had a guy come in, hit by a drunk driver in a crosswalk, 39-year-old vet. Survived 3 tours without a scratch. I spent the last 2 hours coding him.
That's always a rough way to end the night.
Must have had a reason at one time to keep coming back, but I can't think of it right now.
Because this is the job that keeps on giving. Nightmares, ulcers, suicidal tendencies. Besides, if you jump on my shift, that's just rude, man.
Okay, this got really heavy really quickly, but yes, how exhausting is it to lose young patients, especially ones who have, survived numerous tours in Iraq or whatever. But yeah, I mean, doctors have really tough jobs, and this is definitely an emotional, gut-wrenching moment that I feel. And yes, addicted to pain and trauma and martyrs are what most doctors are.
Hope I'm never one of your patients.
That makes 2 of us, my friend.
I got a pregnant teen coming back today for a mifepristone and a small bowel obstruction waiting on surgery for the last 3 hours.
This is called a patient handoff. Patient handoff is when one doctor leaves a shift and there are obviously still patients in the emergency room or on the hospital floors or inside the hospital that need care and attention. So it's a verbal handoff. It can be a written handoff. It can be an emailed handoff. It can be a shared document handoff. As long as it's HIPAA compliant and the patient's protected health information is private. That's all that matters in a patient handoff. There was actually studies on this because they were reducing resident workload hours, and the number of errors that was made with the number of handoffs given was higher. So they were directly correlated. Think of it like the game telephone. When we were kids, we would sit in a circle and play a game of telephone and whisper a secret to the other person. They'd whisper it to the other person. They'd whisper it to the, and by the time it got back to you, it was a completely distorted fact that you said about yourself or whatever the secret was or whatever the story was. So that's just like patient handoffs. So basically, the longer the shifts that people have, the less the number of errors, which sucks because people get really tired, and then being tired is as equivalent to being drunk. So it's kind of this rock and a hard place between healthcare workers, number of hours, and how sharp you are.
Oh, and unfortunately, the Kraken is still boarding at BH.
Still? Guy's been here for a week waiting on a psych bed.
Yep, he's only getting worse. He's catching some Zyprexa disease at the moment, but when he wakes up, God help you all.
I don't know if this is really interesting or not, but they call them border patients, like BOARDER. Nope. Border patients, BORDER, because they're bordering between two different wards. Like this patient's been boarding in the ER, this psych patient's been boarding in the ER for 1 week waiting for a psych bed because for insurance reasons, they're unable to transfer the patient, or sometimes the hospital's full and the ER patient's boarding in the ER and the ER beds aren't as comfortable as the hospital beds. Sometimes it's the same bed that you get transported and stay in that bed, but most of the time the patient rooms in the hospital have different beds that are a little more comfortable, so I've heard. But if you're boarding in the ER, it's never good for you or the emergency room team because you're kind of taking up space from someone that could be treatable in an acute condition. He said Zyprexa disease. Zyprexa is a pharmaceutical name for olanzapine, which is an antipsychotic. And it's a sedative, so you get Zyprexa disease. So that was his funny way of saying it. He's doped up on Zyprexa because he needs to be sedated because he's a psych patient and he must have some hallucinations of some paranoias. You've all been in the ER, so you know how it is when it gets crazy.
I wrote a note for the family of my dead vet if anyone shows.
That's really nice that the ER doctor wrote a note for the family of the dead vet if they show. That's really, really nice. I think I haven't really seen that happen too much in my practice or in the hospital that I worked at, but maybe it does.
Oh, and you got the med students and new interns starting today, so good luck with that.
Lucky me.
Sir, come back here.
No more needles!
Oh!
Sir!
No more needles!
No more needles. Like nurses are chasing a naked patient around the emergency room. That's hilarious. The emergency room is a zoo. It's like a circus. It's so common, such crazy things to happen in the emergency room. And it's so normal for the people that like work, I almost said live, that work and live in hospitals. But for the people that aren't usually there all the time.
Sure you want to work today, huh?
They're gonna hurt me!
Sir, I promise nobody's going to hurt you.
Enough?
I married my second husband, Everett, in 1964. He unfortunately passed in 1976 from a heart attack while we were vacationing in Kissimmee, Florida. It was awful.
Good morning. We're gonna round Dr. Mohan.
Excuse me, Estelle. I'll be right back.
Okay, this patient just gave so much information. She's an older woman. She's sharing her life story, and this resident doctor is sitting there listening to it. And I can tell you, I am that doctor. I listen to the stories because I get to know my patients, and that's really what I'm there for, to make sure that I'm like helping them feel better. But I can see how the attending kind of just gave her a look like we got around.
So, you know we track every resident's patient seen per hour.
I was just taking her
It's a
history.
brief backstory about what brought them in, not an autobiography.
I was almost done.
You hadn't even made it to this century.
Sherry, I'm Dr.
So patients seen per hour, that is a metric that's monitored.
McKay, I have some student doctors with me today. Do you mind if they observe?
Sure.
Okay.
Student doctors is a great way to introduce the medical students and the medical students that graduated that are now residents. Residency is a paid training program after medical school.
What's going on, Sherry?
I burned my hand on a sterno.
What are you doing with the sterno?
Cooking.
You were cooking with the sterno?
We were making.
I don't know what a sterno is. I have no idea what a sterno is, but the doctor's confused why she was cooking with the sterno.
Thanks, Morris.
Sweet. My son loves spars.
We've been here for hours and I have to get them to school. Do you know how much longer this will take?
Yeah. Let's see.
Okay, that sucks. So often patients ask doctors to help them be faster, but the two options are taking care of themselves or getting the kids to school. It sucks that she's in this position.
You take anything for the pain?
Not yet.
1,000 of Tylenol, 400 ibuprofen, and saline dressing?
Yes, please.
That must be a nurse who is astutely on top of it, and he got the orders before the doctor put them in the computer, so he knew what to go grab while she was putting the orders in the computer. And those are accurate doses.
Please.
Okay. Second-year resident, Dr. Melissa King, fresh.
And why you would give someone both Tylenol and ibuprofen for pain is because they act on different receptors. And so often I hear people say, like, just live through the pain, or like, that's just ride the pain. Like, especially in an injury or a traumatic insult, there's no reason to suffer, really. And ibuprofen is an anti-inflammatory. It will not only reduce the pain, but it'll reduce the inflammation, the cascade, the inflammatory cascade. So ibuprofen sits on COX-2 receptors. That's way too much information. Let me back it up. Non-steroidal anti-inflammatory medications, drugs, NSAIDs, that's what we call them, NSAIDs. They're anti-inflammatories. They sit on different receptors than Tylenol or acetaminophen. So therefore, it is okay to use both. And for someone who's had a very traumatic injury, absolutely, use both.
From the VA.
Everyone calls me Mel. I'm so happy to be here.
Trinity Santos, intern.
Victoria Giavati, MS3.
Dennis Whitaker, MS4.
Intern means first year resident. MS means medical student. 3 means 30 years. So they've now introduced a second-year resident, a first-year resident, also called an intern, a third-year medical student, and a fourth-year medical student. Keep in mind, after medical school, you don't just jump straight into being a doctor all on your own. You have to go through a paid training program under someone else's license, which is your attending doctor's license, your attending physician's license. So you're like training wheels before you get to ride your bike on your own. And that's what residency is.
Welcome to the Pitt.
We got 2 traumas from the T. 5 minutes out.
Okay, copy that. Actually, this is the most important person that you're going to meet today. This is Dana. She's our charge nurse. She is the ringleader of our circus. Do what she says when she says it.
Charge nurses run the world, okay? Charge nurses run each floor so meticulously and detail-oriented that if you don't know the charge nurse's name and they don't know yours, like, you're already jacked. As a resident or a med student, pro tip, like, learn who the charge nurse is on that floor and become friends with them. They will have your back, and if they ask you to do something, most likely do it. They're thinking of something ahead of you and don't really have the time to go back and forth with you on it.
Vitals. They repeat a crit.
Stable crits every 2 hours times 3.
Discharge on Sefton. Recheck tomorrow. He'll get way more rest at home. Good morning, Mr. Straker. You want to go home?
Hell yeah.
Okay.
Hey, bro.
Okay, this is something funny that doctors do, which I've done too, which is tell patients that they're ready to be discharged home. And then patients think that that's all that they needed to hear, which is like a verbal, you can go home. But there's also a discharge order that needs to be put in the computer, the discharge medication reconciliation, which means reconciling all the meds that the patient takes at home versus all the medications they need to go home with, and then writing new prescriptions to be sent to the patient's pharmacy of choice electronically, which may or may not have been put in the computer before the doctor starts to do their discharging process. So it's a good like hour and a half or 2 hours from when doctors say you can be discharged versus when you actually leave the hospital. Because after the doctor does their thing and write the orders and do the medications, there's also discharge instructions that need to be written in the discharge packet. That needs to be printed out. Nursing needs to do their assessment and documentation. And then transportation needs to get called sometimes, and they need to wheel the patient out. And then that's when patients are being discharged physically from the hospital. So there's this huge gap in when doctors say you can go home versus when you can actually go home.
We need to talk about your numbers.
Of people we've saved.
Metrics.
Our door to balloon times beat federal standards.
I'm talking about Press Ganey scores.
Of course, there's a person in a suit talking about administration and talking about numbers. But to be fair, he was just talking to the other resident about her numbers and the amount of patients that she's seen per hour. And now his, administration supervisor is talking to him about surveys and score press gainy. Oh gosh.
Patient satisfaction?
If they're still alive, they should be satisfied.
Our goal is 36% very satisfied with their care. Your department is at 8.
Patients get given surveys at the end of their hospital visit or hospital stay, and they actually really, really matter. So if you don't give like 5 out of 5 stars or 10 out of 10 to the 3 questions that are asked about your nurse, the 3 questions that are asked about your doctor, then the hospital gets dinged in a way. And there are metrics, but it's really hard for doctors and nurses to provide that type of care in such a high stress, fast-paced environment. And it always personally bothered me, although I was willing to learn the communication styles that would make patients feel like, okay, they knew what was going on with me and they told me what was going on with me. But to actually hear and understand, this is what I'm supposed to go home and do, take a pill once in the morning and once at night for 7 days, that's different. And so I was always happy to learn that stuff, but it did trigger me a little bit because I would be like, this isn't a Yelp review.
Do you know how likely patients are to recommend this hospital?
This is an emergency department, not a Taco Bell.
11%.
Well, if you want people to be happier, don't make them wait for 12 hours.
There's a nursing shortage across the country.
Most of our patients are boarders who are waiting for a bed upstairs.
We don't have the beds.
That's bullshit. The beds are up there. You just don't want to hire the staff you need to care for.
Okay, this just went way above my pay grade. I don't know anything about hospital administration business. And as much as we like to think of healthcare as a human right and a basic necessity, it absolutely is. And it is also absolutely a business. And I think I just learned that recently. I've been a 10-year hospitalist, and I just now recently completely understood doctors need patients and patients need doctors. It's a symbiotic relationship. Hospitals need patients, patients need hospitals. It's just the way it is. It's no one's fault. No one's right or wrong. It just works that way. That's the end. If you made it to the end, thank you so much for watching. Be sure to comment below and let me know what you'd like me to react to next. As I always say, own your health, own your future.